I think we're ready to get started for all those who've been able to log in and get in buildings. And so we're going to go ahead and get started here. And so we've got an exciting case to show today, and something that is going to be very interesting to you. And so you're certainly, we welcome the opportunity to be interactive on our conference. And so we hope that you will ask questions, and if you are conversing with someone or have background noise, you have to mute yourself for a while, which will help out if that's the case. And so we're going to get started. The patient we got to talk about today is a 47-48 because he had a birthday during our encounter with him. He's male special operations warrior, special forces. We have the SOCOM here at the base at MacDill, and so we have 67,000 special forces personnel in 90 countries around the world. And so he's one of those that we respect and honor. He presented in the outpatient setting. His wife's actually sent him over. She's a nurse, and she's an ARNP. She sent him over because his father had a heart attack at 44, and he's getting ready to retire from the military, wants to be a civilian contractor. And so they want to take advantage of the military to evaluate him before he retires. Apparently, special operations warriors have a higher incidence of heart disease, just like first responders do, police, fire department, fire rescue. And the reason has to be several things. One, a lot of stress, and two, night shift work, and three, sleep deprivation. And so this guy falls under that category, and so we were interested in evaluating him because of that. Basically, his history is that he doesn't have any cardiac history. He has a lot of trauma from jumping out of airplanes with parachutes and hitting the ground hard sometimes, so he had a right ankle surgery. He had problems with his left shoulder. He had neck surgery with cervical plate and screws. He's had self-healing of a left clavicular fracture with malalignment, and that seems to kick up every once in a while, and it gives him some discomfort. He can tell when it's going to rain, which is unfortunate here in the summer because we have a lot of rain. And so he's a non-smoker, exercises on a regular basis, is in excellent shape, as all special operations warriors are. And again, the fact that his father had hypertension and had a heart attack at 44 was the reason why he's here. When we saw him, he had a normal physical examination, as would be expected of special operations warrior. And what to do next is the next question, and so I'm going to ask Pooh, what would you do next in evaluating this guy who is retiring soon? He's military, special operations forces, and has a group that has a high prevalence of coronary artery disease. Pooh.
I mean, we can start off with the basics. I would pretty much do everything that's on the list there. We could start off with the EKG and then echo, if that shows wall motion, and CT obviously would give us any anatomical blockages, plaque, morphology, or anything else. But it's a stepwise thing.
Very good. And you have an EKG. Could you tell us about this EKG, Pooh?
It's normal sinus, some early repose. Other than that, rates around 75. Nothing really stands out so far.
And the ST and T wave changes, what would you call those?
I was thinking they're more like early repolarization. Although over 40, you should be careful, but they're concave up, so they don't look like. And there are no Q waves or anything I see per se.
Excellent.
So it's not meeting criteria. Early repose.
And so we did do an echocardiogram, and he had an LV thickness of 14. There's an overlap in athletic heart as well as hypertensive heart. And so at these low voltages of thickness of 14, that would fall within that overlap. He doesn't have any history of hypertension. His blood pressures were normal. His father had a history of hypertension, and so we called it athletic heart. We also like to screen by doing a CIMT and also looking at the carotid arteries to see if we see any obstructive or non-obstructive calcified or non-calcified plaque. And frequently we're finding plaque in ladies in their late 30s and early 40s as well as young gentlemen, and so this gentleman has some non-obstructive, non-calcified carotid plaque that was present. And so back to you, Pooh. What do you want to do next in this workup?
I don't trust specs too much. I'd go with lipid profile, CRP, sure we can get. Stress echo is an option too, since its functional capacity would be good. It has good sensitivity, but not very high specificity, or we could just go ahead with a CCTA. ETT is an option too. I didn't see that on the list. So, it depends. I guess we'll talk to the patient, discuss options, and come up with a good test.
Excellent. Well, Carolyn Bush is now in the conference. Welcome, Carolyn. We're glad to have you here. I hope you can speak. It looks like you're self-muted right now. And Pooh, would you like to run over the sensitivity and specificity of these tests as you were alluding to?
So let's see. CT, which is right at the bottom, it says it stands out. Sensitivity is 99. Specificity is 89. So far in the list, this looks the highest. Exercise testing starting from the top, 68 and 77. So not a great sensitivity. You can miss. Spec sensitivity is like 88, not bad, but not a very specific test. I think it's lower than 73. But yeah, dobutamine stress echo sensitivity is okay, 81. Specificity is 84. So that's an option if you're trying to avoid radiation or stuff, if that's what he wants. MRI sensitivity is great, 91. Specificity is 81. MR with stress-induced wall motion 83 and 86, and CT is 99 and 89. So percentage-wise, CT stands out so far, CCTA. MRI sensitivity is good, but
thank you.
CT has a higher. Thank you.
So we did do a CT, and we're going to show you our CT. This is a three-dimension volume rendered image that shows the heart very spectacularly in 3 dimensions. This is done without any prep on people who have a heart rate of 60 or lower. Otherwise, we give them beta blocker to get their heart rate down in the early 60s or even in the high 50s. This is the axial images, and you can see that he has some thickening of the left ventricle as we cited before. This is a 75% diastolic image in terms of the time between the R intervals is in the 75%, which should be diastole. We can actually measure the wall easily here, and we can go to an area near the papillary muscle where we can see the cords. And this is diastole, and there's a measurement there. We can try to approximate the septum and measure like there. And so he does have thickening. It's hard to see which side of the septum we're on here because there's no contrast on the other side. So it could be a little less than we got it at. But there are numbers that are pretty much concentric, it looks like. So it looks like concentric hypertrophy. Certainly compatible with athletic heart. Sometimes the left atrium is enlarged with athletic heart. This one doesn't seem to be enlarged. The aorta looks normal. The coronary origins are normal. So let's look at the coronaries and see what they look like. So the 3D volume rendered image shows that there may be some problem in the coronaries here. So let's take a look at that and see what we can find out. So, and we have coronary images. And we can see on the side panel on the right that as we come down the LAD, and you can see where this little blue dot is, shows exactly where we are in the LAD, or in this particular place here. Let's move up. We can use the calcium as a marker. So there's the calcification as a marker. And as we move up, we can see this little thumbprint in the artery that represents a non-calcified plaque that seems to be just opposite the origin of this diagonal vessel that also seems to be involved in this plaque. And then this calcified plaque with some non-calcified area distal to it. And so this is a proximal lesion in the left anterior descending. And we can, we don't know exactly how much that is, but we can see where it is, and we can see there's some distal calcification. We did look at the other coronaries. And the right coronary proximally looks pretty good. Circumflex proximally. The diagonal. And there's some, again, narrowing at the origin of that diagonal. A little piece of calcium there. And so that's the information we have. Let's go back to our slides. So what next, Pooh?
CRP would give us some information. Prognosis, if it's high, then cardiac plus test. I guess it's a group of tests. Lipids, we can get at least baseline one-time thing. Basically, these are just adding to our test, right? If they're positive and CT showing areas of like plaque, which we're not sure. It looks hazy where the LAD diag was, so it might be severe. So this is just giving us more prognostic information. So I'll get them. CRP, lipid panel. I don't know what the plus test includes.
Melody and cardiology at Largo, do you have any questions? I don't think they can speak right now, so we're going to move on. The CAD is a test of 23 RNAs that are messenger RNAs that are detected in the bloodstream and analyzed that's predictive of coronary atherosclerosis. So we don't need that test because we know there is coronary atherosclerosis. This test is trying to find a place, and it's very expensive. I don't think it's found its place or its use yet. It's being marketed to primary care physicians. The PLUS test is a test that's really called the pulse test. I spelled it wrong. I spelled metalloproteinase wrong too, but I apologize for that. The pulse test is a test of 7 inflammatory markers that's used for predicting inflammatory active plaques.
Okay, thank you.
So it looks like what we did was the pulse test, and we spelled it right this time, the pulse cardiac test, which is 7 protein biomarkers that combine with cardiac risk factors that signals the presence of active vulnerable plaque. This is a test that used to be marketed as the MI risk test and now is being marketed as the pulse test and is in Irvine, California. Dr. Harrington is the CEO of the company called Global Discovery Biosciences. And so on this particular test, which has exceeded the Framingham test in demonstrating risk, it showed that the patient had an 8% risk of a heart attack within 5 years, which placed him into a high-risk category. That's quite a surprise for a 48-year-old guy who has known risk factors other than being male and over the age of 40. It also demonstrated that his risk was 5.34 times higher for an acute cardiac event than to be expected of a male the same age. And we have a little distribution of this test to show you. It's a little blurry on the slide, but it shows some ascending risk over here on some of these factors that is used for this calculation on the algorithm. And the factors that we look at are hepatic growth factor, which has to do with cell migration and cell division, Fas ligand, which has to do with tumor necrosis factor ligand, and basically is activated during inflammation, and then the S-Fas protein, which is another necrosis factor, triggering cell death. This is for apoptosis. So the S-Fas is positive for apoptosis. The Fas ligand actually attenuates apoptosis. Eotaxin used to be thought to just cause eosinophils to migrate into a lesion, but it's shown to also cause macrophages to migrate. Interleukin 16 is a cytokine. MCP3, which is monocyte-specific cytokine, or chemokine 3, is chemotaxic for macrophage migration, and then CTAC, which also is a chemokine that attracts cell migration. So all these have something to do with cell migration, usually macrophages, or something to do with apoptosis. Okay, what to do next? Further testing, counseling of lifestyle modification, medical therapy. You want to run through that one, Pooh?
Sure. I mean, definitely we need more testing since his risk is 5.34% higher than the general population, and we saw that vulnerable plaque. CT, lifestyle modification, sure, we needed medical therapy, aspirin, statin won't hurt. Next test, CAT versus FFR. Like, we need some functional study. Like, so far what we have anatomical CT, so we need something physiological, either FFR or a functional test. CAT would be like the gold standard, but we're not sure yet if that plaque is really more than 70% or not. So I do go with FFR, plaque morphology and composition, plus counseling and more testing.
Okay, I see Whitney Harrell has logged in. Hello, Whitney. Welcome to our conference. You're self-muted. And so we did choose to understand more about this plaque. And so this is a whole new field of cardiology that many are not aware that we're in detail mode for plaque analysis. So this plaque, by our measurements here, using Plaque Shear, which is a vital image product on the vital image workstation platform, reveals that the diameter stenosis of this plaque is 54% and the cross-sectional area is 86%. As you can see, the narrowing of the lumen as we go downstream. You can also see, and we sort of exaggerated it so you would see it easier, the red, which simulates necrotic core, and the blue, which simulates fibrosis. If you saw yellow, that would be simulating calcification, which you can see distal on the linear model here, the longitudinal model. On the cross-sectional images, you get an idea that there's a lot of necrotic core, and you see the necrotic core frequently is abutting the lumen or the channel of the vessel. The channel is signified by the green, which is color-coding the contrast. And so there are several areas where it's strongly adjacent to the necrotic core, where you wonder if that could rupture through. We can't measure in terms of micrometers the distance of the necrotic core to the lumen. That can be done with OCT, where you can actually measure anywhere above 65 to 85. Below 65 is a thin fibrous cap. Above 65 in the 85 range is a thick fibrous cap. IVUS can tell you a little bit about it, but it can't measure it. It doesn't have the sensitivity that OCT has. Here's some more information about this plaque. And this is very interesting because, again, you see the fat plaque that we're focused on. You see there's a distal calcification distal to the plaque. You see the narrowing the lumen. You see the red necrotic core. And actually over here we can actually break out the percent area of necrotic core, fibrosis, and calcification. And we can actually give you numbers on that particular area of the plaque, as well as numbers on the whole plaque. If we want to close in these measurements of the plaque, we can actually give you through the whole plaque what the plaque burden is in terms of necrotic core, fibrosis, or calcification on this particular plaque. So that's interesting. Other interesting things are hemodynamics. And so we have taken this plaque and we've broken it out into just the contrast. And you can see the contrast being very bright orange on both sides here. The plaque is the black part, and this is one part of the plaque, and this is the other part of the plaque, and this is where it's approximating to give the narrowest area, or the so-called throat of the obstruction. And so you can see this creates a convergent, divergent double cone if you think of this in 3 dimensions. And so that's like a rocket nozzle. A rocket nozzle is used for thrust. And thrust has to do with velocity of gases going through it. In this case, we have a fluid, and the velocity of the fluid is going to increase as it goes through this narrowed throat, where the pressure will drop and the velocity will increase, and then the pressure drops on the other side, and then we get eddies and vortices like those coming off of a jet engine. We can show you some more information about this particular plaque, and this is what Bernoulli has to say. Pooh, what does Bernoulli have to say about this plaque? Just in a nutshell.
That we'll measure the pressure before and after, and like drop in pressure significantly. So area volume into area is flow, and flow proximal and distal we'll measure and see if there's a drop, and then recovery after that.
So Bernoulli is telling us that at the highest velocity, which is here at the throat of this vessel, at the highest velocity, the pressure inside is at its lowest. And so that's the one thing you don't want, because the pressure inside the plaque is balanced by the pressure outside of the plaque. And so if you've got the lowest pressure right here at the top of the plaque, then internal pressure may at some point exceed external pressure in the plaque, and that would cause plaque rupture. So there's a lot of concern about what this pressure number is at the highest velocity, which is the narrowest throat of the convergent divergent double cone. More information has to do with computational fluid dynamics. And most people always thought that wall shear stress, which is measured up here, WSS, and which is measured here, WSS, wall shear stress. And this little blue line is measuring wall shear stress. And you can see the little blue line just has a little tad of elevation at the throat of the lesion. You almost can't see it. There's just a little blip there. And up here you can see the yellow vector, and you can see the intensity of the vector is very low because the arrow is short, and you can see that the vector direction and the wall shear stress is minuscule. It's just so small. It's minuscule compared with the stress that is caused by axial plaque stress, and the axial plaque stress is being measured this way, the red line, as it's going up and down, and you can see the axial plaque stress is very high, and it looks like it's probably 30,000 times higher than the wall shear stress. So this is the important vector that has to do with the pressure and has to do with this high velocity flow across here, which is actually taking this plaque and pinching it like a pimple where the pressure is lowest at the top. And there's eddies and currents that are backfeeding this, and also there's reflective waves that would come off of the calcification that's distally and rebound on the distal shoulder of the plaque. So the hemodynamics are very, very severe in this plaque, which makes it extremely interesting. So the next part of the analysis of the plaque is even more detailed, where you see here our three-dimensional picture of the heart as a volume rendered picture, and then you see the blurry images that we see in terms of resolution when we're looking at the calcification, we're looking at the contrast that's flowing through the vessel, and there's something called subvoxel resolution evaluation that a computer program can do that is actually producing a lumen that is much more recognizable, as well as a side branch that's more recognizable with a resolution that becomes 0.25 millimeters, which is a much better resolution than we had prior to computer processing of this. And then you can see the myriad of vessels involved in the coronary segmentation. This is the 3D mesh generation that is used in computational fluid dynamics. There's a quantification of the resting coronary flow, and then there's a calculation of microvascular resistance applied to each vessel. And you can see how important that is, because this patient had the athletic heart, which means that his heart muscle's a lot thickened, which means that there is a greater density of capillaries per myocardial volume, and that means that there's a higher resistance in that myocardium. And so then measuring hyperemic changes and basically producing a model as if adenosine was given, which is interesting because that's the test we do when we do FFR in the cath lab. And then these are the calculations that are used, which are the Navier-Stokes equations that have to do with the x-axis, the y-axis, and the z-axis in terms of calculating blood flow millimeter by millimeter to produce the FFR. So this is the process that a supercomputer goes through in applying these calculations to produce the FFR information, which is on this image. And so this is very exciting because it shows us the image that paralleling the color-coded image of flow and FFR. FFR has to do with flow. Blood pressure is proportional flow, and we're measuring the blood pressure drop across the lesion. And here's the lesion, and here's the distal calcification, and here's that lesion. Here's the distal lesion produced by the calcification. Here's an upstream piece of calcium as well. Here's the diagonal that seems to be a similar compromised sort of borderline in between. And the FFR, if it's less than 0.80, is considered significant for decreased blood flow distally. If it's greater than 0.80, it's considered normal. And in this case, the calculations show it's 0.50. We do this in the cath lab. This is comparable to the cath lab calculations. Any comments from anyone or any questions about this? We have Janet Olson on. Hello, Janet. Alan Chen. Alan, do you have any comments or questions? You are self-muted. Pooh, any comments or questions?
No, looks impressive, 0.50.
Pretty impressive.
Right.
What to do next? Further testing, counseling on lifestyle, medical treatment, cardiac catheterization. Remembering that this gentleman just came in for this testing to find out his risk of heart disease because of his father having a heart attack at 44. He's going into retirement soon. He's never had a sick day in his life other than some broken bones and stuff, which he thinks is basically part of doing business. And so, Pooh, any comments about where you would go with this?
I mean, God, at this point, FFR is significant. Most likely he'll, if we do it empirically, we're preventing heart attack or STEMI or something which might happen. So, plaque rupture.
So we're not at the point where we're willing to be interactive and prevent heart attacks on asymptomatic people. And so when I called an angioplasty doctor and we had a discussion, he wants to know, well, what's the diameter of the stenosis? And I told him what we measured. And he wants to know, well, who's going to pay for this, you know? This is not someone who's having symptoms. How are we going to justify this? And so there were lots of questions that were brought up, even questions by the patient who said, hey, I just came over to get this test. I don't want to get a catheterization. I'm fine. I don't need anything done. So basically we settled for aspirin, Plavix, a loading dose as if he were having a heart attack, atorvastatin, 40 milligrams a day, metoprolol succinate, 50 milligrams, and said, here are these prescriptions. And this asymptomatic gentleman who said, what is this for? And we said, well, we found this plaque, and we actually got online and showed the plaque to his wife, who's a nurse, and she was at work, and she got on the computer, and she was very impressed with the plaque. And the gentleman doesn't understand any of this, and he says, what? Okay, well, what am I supposed to do with this? And we said, well, go to the pharmacy and get the prescriptions filled. And we saw him on Thursday, and on Friday he went to the pharmacy and got the prescriptions filled. We talked about left heart catheterization. We talked about potential angioplasty. It was during the holidays. We weren't even sure if he would consent to it or if the insurance company would cover it. We talked about looking at that later after the holidays, during the Christmas holidays. And so, we talked to Abbott about the bioavailable vascular scaffold and whether they would be interested in paying for that in a patient who's asymptomatic who may have a stenosis that, although angiographically it didn't look too severe in terms of our CT scan, it certainly had a reduced FFR. They didn't want to touch it. So 4 days later, which was Sunday, he was playing an interactive video game. The game actually was a thought game. And as you know, when you play video games, even if you play thought games, not just shoot 'em games, there's been studies done, like Robert Elliott at the University of Nebraska, where they studied what happens to your blood pressure and heart rate, and what happens to your stress level, epinephrine release, all these things that happen when you're playing a video game. And it is a big-time stressor. As a matter of fact, it's been used for stressing people to see if you can cause angina, and sometimes does. So it's very interesting. So he was playing a video game, and he starts getting some discomfort in the left clavicular area where he has the fracture that's remodeled. And so when he starts getting that, it's something that he feels all the time. He thinks it's going to rain, so he says to his wife, I think it's going to rain. And then she looks at him, and he's sort of sweating, and she doesn't like his color. And she has seen a picture of the plaque, and she's much more impressed by that. And she said, well, Dr. Harrison showed me that plaque. I'm really worried about you. I'm calling 911. And he's kind of shrugging it off and saying, no, you don't have to do that. And she calls 911. So the paramedics come, fire rescue comes, and here's this 12E relead EKG. Pooh, what do you think about this?
Wow, anterior STEMI, V1, V2, V3.
So we got
the elevations there.
Yes.
And we saw that LED plaque.
So he is having a heart attack, and fire rescue does a 12-lead EKG, which is not unusual nowadays. That's done frequently. Here in Tampa, we started fire rescue coincidental with Miami and Seattle, And so we actually had EKGs transmitted from the street to the coronary care unit, read by the nurse in 1972, which is kind of remarkable. And so here's his anatomy. And you can see he has a totally occluded left anterior descending. That's exactly, in terms of measuring, it's exactly at the site that we had calculated looking at his CT, and it's exactly where that very complicated plaque was. You can see that he now has a stent put in there. Here's the diagonal that's next to it, and so you can see, using that as a marker, you can see exactly what it is. And so that we can understand from the fiducials, which is what the computational fluid dynamics use in terms of locating markers. They call those fiducials, not fiduciary, but fiducios. We did an echocardiogram when he arrived at the hospital to get some idea of wall motion, and then we did another one afterwards to see if there's resolution. And indeed, in 48 hours, his function was back to normal. Pooh, what kind of test would you think doing now?
I mean, EF's normalized, so I mean, maximal medical therapy will continue.
So we
wanted a test.
Yes.
MRI. I would medical therapy for sure. For stunning, it might have been stunned. That's recovered. I mean, so yeah, aspirin, morphine, statin, beta blockers.
Well, actually, he has normal ejection fraction, but we wanted to find out if there was any residual damage. And so we decided, after a reasonable wait, in terms of resolution of edema and stuff, that we would look and do an MR to see if we saw any residual damage that might be subendocardial and may not be transmural. So let's look at his heart and see how it beats. How does this look to you, Pooh?
I mean, while walls are moving, there's some late enhancement, but EF looks okay even now. It's coming in nicely.
So
anterior wall has some, is this scar, why is it like that area a little more shine?
So we can see that,
exactly.
Indeed, you're right that we have nulled the left ventricle with the MRI, and after nulling the left ventricle, which would make all of the wall black, basically you can see that with late gadolinium there is enhancement of an area of the subendocardium that extends from the anterior wall down to anterior apical, and this represents an area of not transmural but more subendocardial infarction. So there has been permanent damage, you just can't see it because most of the wall thickness is preserved, so it's dragging that scar part tissue with it. And so we can show you more pictures of the same. Hang on. And this is another picture of his contractility, which looks excellent. So there's well-preserved contractility. At the same time, there's subendocardial scar. And this is a good picture of the left ventricular subendocardial scar. This is left ventricle, this is the cavity, this is the lateral wall, inferior wall, this is superior area, interventricular septum, right ventricular wall, right ventricular cavity. And so as we march through there, you can see that there's considerable subendocardial damage with late gadolinium enhancement, which is basically an excellent test for looking for damage. So we want to know if he had any damage. He does have damage. And so this is his picture We had to protect his identity by covering his patch and covering his face, but you can see he's in full uniform, and now he works as a civilian contractor, and he have gun will travel. We'd like to tell you more about predicting heart attacks, and so we'll quickly move through this and talk about he had a triple positive finding in that he had vulnerable plaque characteristics, positive FFR, and positive pulse tests for inflammatory markers. This is the traditional cardiology algorithm. This is called a six-pack: history and physical, EKG, echo, SPECT scan, cardiac cath. Did you know that if a cardiologist touches a patient, the expense to the medical system average is $7,000? Part of that is the lack of specificity of the testing. And so the gatekeeper is considered the SPECT scan, and the SPECT scan in Blue Cross Blue Shield of Michigan has a 40% false positive, 65% false negative. That means of 100 patients who don't have heart disease, 40 of them are told that they do. Of 100 patients who do have heart disease, 65 are missed. This is basically office SPECT scanning, hospital SPECT scanning. It's not, Dan Berman at Cedars-Sinai. It's not Franz Wackers or Hans Wellens. People write all the articles. It's what's happening in the trenches. We also, when we looked around, found that here at our hospital we have a 50% false positive, 50% false negative. Other hospitals we found an 80% false positive. Ottawa, Canada, our Canadian cousins, have an 88% false positive. And so I want you to understand that this test is flawed in its current use. Although most people will say, well, I do a pretty good job. I try to read around the artifacts. Well, the artifacts are so common. They're produced by attenuation from the breast or from the stomach. And so breast in females, stomach in males. And unfortunately, although each individual reader thinks that he is doing a good job, altogether, it's not a good test, and they're not doing a good job. An alternative to this test, well, let's show you what happens. This is the flow in the hospital at Memorial, where the patient is seen in the ER who has low or intermediate risk. He's seen by the cardiologist. He may have a troponin, EKG, perhaps there's a front-loaded echo. The SPECT scan is done perhaps the next day if he's admitted at night. It's not done during the nighttime. The next day he has the test. The test is a 5-hour test. You have rest and stress test. It's then reviewed by the interventional cardiologist who comes back at night. Then you transfer the patient to Tampa General, and then 60% have a negative cardiac cath. And so it seems like a very inefficient system. And an alternative, which would be called value-based cardiac imaging, would be you get more for your money and you get a better selection of tests in terms of resolving whether the patient has coronary artery disease or not with CT scanning or with a functional test like MRI. You saw the statistics on sensitivity and specificity. CT scan we have priced out for a step and shoot iDose, which is a very abbreviated CT scan, a 10-minute test for less than $300. The MRI sells for about $500. You see the SPECT scan is $1,367. Cardiac cath, $7,000 as an outpatient. Angioplasty and open heart surgery. So this is a more strongly value-based testing regimen with CT or with MRI. It also results in decreased length of stay, where you can recycle the patient back to the emergency room after having the CT scan, show them the results, and if it's negative, they can be immediately discharged home. We can select those patients that are low or intermediate risk. We can select those with negative first troponins or negative second troponins and process them through this. People who basically can't have the CT because their heart rate's going too fast, If they can't have a Lexiscan CMR because they had coffee, which many people have when they showed up in the ER, we can do a dobutamine CMR test, which is called a dobutamine sync, where we can actually get the wall motion information from a single heartbeat, which is a very unique approach. And you can see it real time actually as it's done. You can see these images that have been post-processed immediately showing wall motion abnormalities induced by the stressor agent. This is something to tell you a little bit about the evolution of coronary imaging, and especially cardiac imaging. This is not imaging the arteries directly until we get over to the later phase of CT. But this is the Anger camera that was basically invented by Dr. Anger 40 years ago and evolved into from planar imaging into SPECT scanning. And these are some of the dirty images that we see. And this is actually with attenuation correction, where the images have been cleaned up and they're still pretty dirty. And so basically this explains why we have 40% false positive, 65% false negative. This is called the Kuhn cycle. As we drift through this, you see there's been some model drift and now model crisis, where basically many hospitals, including ours, have a 50% false positive, 50% false negative, which is the same as a coin flip. And so as we go into the evolution of 16 slice, 64 slice, 312 slice scanners, we can see that we're getting beautiful pictures of the coronaries. We're getting very specific plaque analysis. We're getting FFR, which is coronary blood flow, which is done in the cath lab, as well as with CT, and it's correlating well with CT. And this is something to show you the images that can be produced by analyzing dobutamine or Lexiscan MMR. Why change imaging platforms? Well, as you see, there's a 50% false negative, 40% false positive, up to 80% false positive. 60% of patients having cardiac cath do not have significant blockages, and they're put at risk with the procedure of complications. Frequently lesions, about half of them, that are called severe angiographically by visual inspection are not flow limiting by FFR. FFR greater than 80 do better without angioplasty with medical treatment. Less than 80 do better with angioplasty. Less mortality, they live longer, they have less heart attacks, less downstream readmissions. Only 6% of patients in the cath lab are getting FFR nowadays. The CTFR, which is being brought to market very slowly, is equivalent to the intracoronary angiography FFR. CT has less radiation, more sensitivity, is done faster than nuclear scanning. Stress CMR is more sensitive, faster with no radiation than nuclear scanning. Calcium scoring and what happens within the vessel was very interesting. And the calcium score is a surrogate marker for the total burden of plaque. I'm interested in the actual plaques, what they look like, not actual calcium score. The calcium score actually reflects what has happened to a plaque as it's transitioned from being a dangerous plaque to being a neutralized plaque. It gets neutralized by calcification and actually pushing out, called remodeling, and it's like paving over the necrotic core to render it neutral so it doesn't cause problems. So the dense calcification causes a lot less problems than necrotic core. As a matter of fact, in terms of significant stenosis, 25% of heart attacks are caused by significant stenosis, whereas 75% are caused by blisters that rupture. Statins accelerate this transition of this equation going from left to right and winding up with dense calcification. Sometimes this is the end of the process and there's no more plaque being added on this end, and so all you see are calcification and it remains the same for years. Sometimes the process is continuous and we keep getting necrotic core, fibrofatty, fibrous, and dense calcification. And so you can see we're interested in total burden of plaque, we're interested in necrotic core, we're interested in new plaque deposition, we're interested in shifting from this equation from left to right to decrease the incidence of having an acute coronary insufficiency. And so This is basically what things really look like, and this is our cartoonish identification of necrotic core, of the channel, and of fibrosis. Again, as Rob has put together here, you can see that we're very interested in this composition and the ratios that take place inside the artery. We're also interested in the characteristics of the anatomy, not only function, but the percent diameter stenosis, the percent necrotic core, the distance and pointing of the necrotic core, thickness of the left ventricle, diastolic blood pressure, spotty calcification, napkin ring lesions, convergent, divergent, double cone lesions, all these things, proximity to the origin, plaque internal surface area, plaque greatest stenosis area, all these things are very interesting to us in doing plaque analysis with the information that we have. What changes downstream when we go to CT and MRI? We get lower radiation exposure. You don't have to wait for isotopes, faster throughput. Negative CAS drops from 60% to 21% normal CAS. Less patients readmitted. Less patients go home and have heart attacks. More bypass surgery occurs because of the greater recognition of severe stenosis. More CTOs are found for angioplasty if you're into chronic total occlusions, and it's greater specificity for which vessel is responsible for the ischemia or the symptoms the patient is having, and less length of stay. And basically, these are what the blisters look like that we're studying, which this little red spot is one of those blisters. And this little red spot is another blister. This is our patient. These are what stenotic lesions look like, and these are what the blisters look like, which are much more important. Our mission is to identify this in asymptomatic patients. And so to do that, we have to see them first, and we have to have a test that is quick, easy, very low radiation exposure, and is affordable, which we have. This is our center with our clinic. This is our center for cardiac imaging with cardiac MRI, cardiac CT, and cardiac PET. This is our core laboratory where we have, this is where we took an outpatient radiology center and turned it from outpatient PET, MRI, and CT radiological studies, added on to each piece of equipment to make it cardiac so that we could do cardiac tests as well. The core laboratory where I'm sitting right now has like $600,000 worth of hardware and software, and we have 5,000 case experience. This is the emergency room that we're going to be converting into CT MRI platform with this formula that we use as a pilot project for HCA to try to identify the use of CT and MRI in terms of length of stay, saving money, evaluating patients. And we've been doing that for some time now, and it saves a lot of money. Patients go home a lot faster, and it's a quicker, less radiation exposure test that gives us answers. And so we're pretty happy with that. Here's our new dobutamine spec sync study. You can't see it very well. We're just bringing that into the arena for testing. It's approved by the FDA. It's called dobutamine sync, 1 heartbeat, and you can tell what the wall motion is. And these are some of our references for our meeting today. So thank you so much for attending, and we'd like to see if anybody has any questions. Any questions out there, anybody? Alan, Carolyn, Janet, Carenza, Mary, Michael Cogger, Mindy, Pooja, Renee, Sandra, Shannon, Sharon, Teresa, and Whitney. Any questions? Okay, I know that you all...
Great lecture, thank you.
Thank you so much for attending. We really appreciate it, and we'll see you next week.
Thank you. All right, thank you so much.
Bye-bye. We do have a recording, and we are going to post this online, and we'll let you know where it's being posted. Bye-bye. Have a good day.
Thank you very much. Bye.